process of the onset. A sudden unexplained headache at any location should raise suspicion of a subarachnoid hemorrhage and must be investigated. Okay, so with rupture, blood at high pressure gushes into the subarachnoid space, resulting in the following three patterns of presentation. Patient is stricken with severe headache and vomiting and falls unconsciously, and which can be very immediate. Okay, there could be severe generalized headache, okay, with varying degrees of neck stiffness, okay, and rarely some patients just become unconscious without any preceding complaints, okay. So this is just one of the presentation of cerebral aneurysm rupture. So the pain can be felt on the occipital and the posterior cervical area, okay, and may signal a posterior inferior cerebral artery or an anterior inferior cerebral artery aneurysm rupture, okay. Pain in or behind the eye and in the low temple can occur with an expanding MCA aneurysm. So the presentation of the patient, the symptomatology varies depending on the location of the aneurysm. So in terms of the classification of stroke, those patients who present with subarachnoid hemorrhage actually are about 5% of these cases. Okay. So with that, excluding head trauma, the most common cause of subarachnoid hemorrhage is a rupture of a saccular aneurysm. Other causes I've mentioned are vascular malformations. Okay. So if the patient survives but the aneurysm is not obliterated, the rate of rebleeding is about 20% in the first 2 weeks, 30% in the first month, and about 3% per year afterwards. The annual risk of rupture for aneurysm is less than 10 millimeters in size is around 0.1%, and for aneurysms greater than 10 millimeters in size is around 0.5 to 1%. Okay, so I'll just skip some of this. So this is just a picture of what happens when the aneurysm ruptures. The weakest point is the tip of the aneurysm, okay? And then the presence of the blood in the subarachnoid space will trigger the vasospasm in the surrounding vasculature, okay? In less severe cases, consciousness, if lost, may be regained in minutes to hours, okay? So it's actually a form of neurogenic shock. Just imagine when the aneurysm ruptures, there is a sudden gush of blood into the subarachnoid space, and therefore would actually cause some degree of a neurogenic shock. And these patients present with unconsciousness, okay, and then they immediately, be brought to the hospital, and by the time we see them, the blood pressure is elevated. So the natural history of subarachnoid hemorrhage secondary to a ruptured cerebral aneurysm may be initially be due to a neurogenic shock. There could be hypotension first, unconsciousness before a compensatory hypertension. Okay, how about focal neurologic deficits? This may actually occur, okay? There could be third nerve palsy, sixth nerve palsy, or there could be unilateral blindness. The reason why I'm showing you this is that just to emphasize the fact that not all subarachnoid hemorrhage can actually present the same way. It depends on what aneurysm location is, and that's actually the reason why there are varying presentations. All right, so I said that already. You should also look into the other differentials before you actually diagnose the patient of having a subarachnoid hemorrhage. So these are just 4 major causes of delayed neurologic deficits. These are re-rupture, hydrocephalus, vasospasm, and hyponatremia. Okay, so re-rupture is quite common during the first month. I mentioned that already. And re-rupture is associated with a 60% mortality, and the outcome is very poor. How about hydrocephalus? When does this actually happen? It may happen early or may happen late. Okay, so just imagine that sudden increase in intracranial pressure that would trigger an acute hydrocephalus, and then the patient may present with stupor and coma. Therefore, it has to be addressed accordingly. Whether to do a VP shunt first before the clipping of the aneurysm, or wait a little more time before a VP shunt be placed after the clipping is done. Okay, so that's that. Vasospasm, okay. Vasospasm, as I've mentioned earlier, is due to the presence of the blood in the CSF, and signs of ischemia appear 4 to 14 days after the hemorrhage, and the peak is on the 7th day. Another thing that may happen is hyponatremia. Hyponatremia may be profound and can develop quickly in the first 2 weeks following a subarachnoid hemorrhage. There is both natriuresis and volume depletion with subarachnoid hemorrhage, so that patient becomes hyponatremic and hypovolemic. Okay? So there are also other systemic changes, and these are ECG changes, decrease in ejection fraction, okay? And I'll show them to you in a while. This is just to show you some slides, angiograms showing vasospasm of your basilar artery, ICA, and vertebral arteries. Okay, so that's that. So I'm just emphasizing the fact that when aneurysm ruptures, the blood accumulates in the intracranial cisterns rather than intraparenchymal. Okay, this is just another picture of a ruptured ACOM. Okay, and usually it is interhemispheric in location. Okay, so a lumbar puncture may be warranted when the CSF becomes grossly bloody, okay, and so that a proper diagnosis and management can be done. In terms of ECG changes, this may be secondary to the catecholamine surge, and most of this actually present as ST segment changes, okay, and as you can see, there is ST depression, T-wave inversions, okay? And on echo, this reveals a pattern of regional wall motion abnormalities that follow the distribution of sympathetic nerves rather than major coronary arteries, and this is commonly known as the Takotsubo cardiomyopathy. So in terms of treatment, the medical management is focused on protecting the airway, managing blood pressure, preventing rebleeding, manage vasospasm, treat hydrocephalus, treat hyponatremia, prevent pulmonary embolism. Okay, so that's that. So in terms of giving, in managing raised ICP, first and foremost, we need to hyperventilate the patient mildly only to a targeted ETCO2 of at least 32 to 35, okay? Because there are cerebral oximetry evidences that when we hyperventilate our patient below 32, the cerebral perfusion pressure is actually compromised, okay? And that may lead the patient to ischemia. These are little things that we may not be realizing, but we're pushing the patient to further neurologic compromise. In terms of blood pressure, prior to a definitive treatment of the ruptured aneurysm, care is required to maintain adequate cerebral perfusion pressure while avoiding excessive elevation fall of arterial BP. If the patient is alert, it is reasonable to lower the blood pressure to less than 150 systolic, and the drugs that you can actually safely use are beta blockers. These are labetalol, esmolol, and also calcium channel blockers like nicardipine. Avoid using nitroglycerin. Avoid using this drug because it can result to a what you call this cerebral vasodilation that may compromise the patient. If the patient has a depressed level of consciousness, then ICP should be measured and the cerebral perfusion pressure